Yes, okay. So I'm Dr. Ashley Ellis. I was born and raised in Fairbanks. I went away to school. I actually played hockey in undergrad at University of Maine, and then I went to optometry school at Pacific University in Oregon. And then the last 5 years I've been living in Oklahoma City. My husband was in the military, and so this past year he finished up his service, and then we moved back here to Fairbanks in May of 2020. So I'm happy to be back, and I'm practicing at West Valley Vision Center. So I'm gonna go ahead and share my screen so that we can see my presentation. I'm gonna talk today about diabetes in the eyes and how it can affect a lot of different aspects of the eyes. Okay, can everyone see that presentation?
It looks great to me, Dr.
Okay.
Ellis.
Okay, sounds good. So I'm gonna just minimize the screen here. So if you have any questions, you can just type in the chat box. Diabetes in the eyes, I'm gonna just jump it right in there. So diabetes is a group of metabolic disorders that is highlighted with high blood sugar, which is hyperglycemia. Oh, there we go. So why do we care about diabetes? 34 million Americans have diabetes, so 1 in 10 people. 88 million Americans have pre-diabetes, 1 in 3 people. And there's new cases of type 1 and type 2 significantly increasing among the US youth. There's projected to be 33% of adults in the US can have diabetes by 2050, so that's a third of the population. And it's the #1 cause of kidney failure, lower limb amputation, and adult blindness. So I particularly care about this because it can really impact my patients. A third of patients with diabetes do not receive annual eye exams. And so we're going to talk about the importance of that and the different things that we can detect in an eye exam. The different types of diabetes. So type 1 is thought to be due to autoimmune reaction causing the body to stop making insulin. This is typically diagnosed in children and young adults. Type 2 is when the body doesn't make enough insulin or it can't use the insulin as well as it should. This can be diagnosed at any age, but is often in middle-aged or older adults. Gestational diabetes occurs during pregnancy, and it typically resolves after the baby is born, but this also contributes to a risk factor for developing type 2 later in life. There's also pre-diabetes, so the blood sugar can be higher than normal, but it's not high enough to be diagnosed as type 2 quite yet. And patients who are pre-diabetic, we get concerned about type 2, whereas type 1, typically you're not going to be diagnosed as pre-diabetic initially. You're just going to have the symptoms of type 1 diabetes to be diagnosed. So different risk factors, family history, age, ethnicity, race, being overweight, our physical activity, if you're diagnosed with hypertension, abnormal lipid levels like high cholesterol, any autoimmune conditions, and then if you have a history of gestational diabetes for a female. Those are a few risk factors. Symptoms of diabetes, so increased thirst, increased urination, increased hunger can all be some symptoms. You can also have just general fatigue. Blurry vision in general can be one of the first symptoms. You can have numb or tingling hands or feet. You can also have sores that heal really slowly, especially on extremities like your feet. You can have unexplained weight loss. And then you can have high blood sugar. Now, I put that under symptoms. That's technically a sign because you're going to be that's a measured condition. But some patients will experience the symptoms of high blood sugar. They'll feel like their blood sugar is high. So that kind of can be a symptom as well. So the diagnosis of diabetes technically is if your HbA1c, which is your glycosylated hemoglobin, is over 6.5%. So that measures the average blood glucose over the previous 2 to 3 months. There's also a few different other ways. The fasting plasma glucose level over 126 milligrams per deciliter, the 2-hour plasma glucose level, or random plasma glucose level over 200 milligrams per deciliter can also be a diagnosis. Now, sometimes, depending on a patient's profile, then the doctor managing may or may not say it's diabetes, depending on if you're working on your diet and exercise. I've seen some patients who are at a 7.0 and their doctor still diagnoses them as just pre-diabetes because it's the first time that it's popped that high, but then they work to get it down lower. So talk to your medical doctor about that. So general complications of diabetes, cardiovascular disease, neurological diseases, neuropathy, which is that tingling or numbness, kidney damage, foot damage, you can have hearing impairment, and then eye and vision complications, which obviously is what I care about in my professional world. So diabetes causes damage because the high blood sugar can lead to damage of the blood vessel walls, which cause blood and fluid to leak outside of those blood vessels. When this happens, cholesterol deposits can try to protect the blood vessels by lining those blood vessels, which then try to prevent additional damage. But this can lead to narrowing of the vessels, which then raises blood pressure and can increase the risk of clogged arteries, which is the atherosclerosis. The eye specifically in general is the only place that we can see blood vessels directly without imaging or surgery. So we're able to look through the pupil, the black spot in your eye, and we can see live blood vessels working. It's a really amazing place that we can assess for diabetes. Diabetes can affect almost every part of the eye, and we can say that whatever is occurring in the blood vessels in the eye is also occurring in the rest of the body. So in the brain, the kidneys, and the feet. So if we see that there's some damage to blood vessels with leaking blood or lack of oxygen, we can also assume that that's happening in other areas of the body.
Dr. Ellis?
So, yes.
Hey, I already have a question. This is Sandy.
Yeah.
Here, let me turn that on. So I have heard that sometimes doctors can actually go, gee, you better talk to your primary care doctor, or you may have, about your, get your blood sugar checked because of what's going on in their eyes. And it may be the first sign that anyone sees. Would you see something happening in a patient's eye before? I mean, is that an advanced sign, or is that something that happens right away that you would notice in someone's eye?
Yeah, so kind of depends on what it is. I think usually what they're talking about is what's called diabetic retinopathy, which we'll go over later in the talk. But a lot of times that can happen even if it happens with blood sugar. So if you have high blood sugar, then you're going to have that. A lot of times it happens over time. It's usually, well, we're going to talk about this as well. A lot of times patients will get diagnosed with type 2 diabetes, and they may have had blood sugar problems for a long time before that. And so that's kind of the patients who you're going to see and pick up on the eye exam. You're going to see, oh man, we have some bleeding in the back of the eyes. They're probably going to have had blood sugar problems for a while. Even if you have really good blood sugar control, you can still have issues, but it definitely is going to increase the risk when you have uncontrolled blood sugar. So for an extended period of time. I don't know if that answered that question very well, but.
Oh, thank you.
Yeah, it's going to be, I guess, yes, it's going to be in more uncontrolled patients. Okay, so going back to just different complications of diabetes with the eyes. So we can have general visual function issues. We can have issues with the eye muscles, the ocular muscles. We can have issues with the pupils, the conjunctiva, which is the clear film of the eye, kind of like the saran wrap of the eye. The tear film, the cornea, which is the front windshield of the eye. I don't know, can you guys see my pointer? I don't know if you guys can see my pointer. Okay, so I'm gonna point to those structures then. So the pupil, which is the black spot in the eye, the conjunctiva is covering the eye on almost like covering the white part of the eye. The tear film is throughout the whole front surface of the eye. The cornea is the front windshield of the eye here. The iris is on the inside, that colored part of the eye. The lens is on the very inside of the eye, behind the colored part of the eye, which focuses light to the back of the eye. The vitreous is the jelly-like fluid in the back of the eye. The optic nerve in the very back is the kind of like the cable cord from the eye to the brain. And then the retina is the back film of the eye. So we can have issues and complications with diabetes in every single one of these structures, and I'm going to go through each of them individually now here too. Okay, so general visual function. So in general, we can just have loss of visual acuity, which is that 20/20 crystal clear vision. We can have prescription changes. We can have changes in color vision, changes in focusing efficiency. We can have peripheral vision changes, and then changes in contrast sensitivity. So how well we can see things in like dark light. If something is white and a little bit yellow, are you able to tell that difference? And so that's contrast sensitivity. I'm going to talk specifically in that category about prescription changes. So when the blood sugar is high, the natural lens of the eye can swell, which causes changes in your prescription. Signs or symptoms of this can be just blurry vision in general, and then you can also have eye strain just from trying to focus through that change in prescription. It typically occurs with uncontrolled diabetes, and it may occur during medication adjustments or changes. So if you were to have really uncontrolled diabetes, and I kind of use the baseline of an A1C over 8, you may update your glasses prescription, and then you may get better blood sugar control at a later time, and your prescription can change and those glasses might not work anymore. So if you go in to your eye doctor and you're having a lot of issues with blurry vision and they say, oh, your prescription just changed, they may ask you about your blood sugar control, and there may be a recommendation to not update your prescription until you get your blood sugar under better control, because if you change your glasses and then that blood sugar changes, then you can have glasses that don't work anymore because your eyes will revert back to the original prescription. So, okay, on to the next category. So we can have eye muscle issues. One of the big things is a cranial nerve palsy. And so you can there's a bunch of different nerves that go to the eye muscles. And so we can have issues with the nerves transmitting the signal to the eyes to move, to the muscles to move the eyes. And so we can have cranial nerve 3, 4, or 6 issues. We can also have an eyelid droop. We can have pupil changes in how active the response is, or if it maintains that really small pupil in bright illumination. The conjunctiva, which is that clear saran wrap that I was talking about over the white part of the eye, has a lot of blood vessels, and so you can have microaneurysms in that area. You can also have higher risk of infections, which is called conjunctivitis. And so that's definitely something that we want to try to avoid. And then diabetes can also affect the tear film. It can increase dry eye issues by causing damage to the blood supply that goes to the gland that produces the tears. So if we don't have good blood supply, we can produce less tears, and then that contributes to dry eye issues. I'm going to talk specifically about the muscle palsy in this situation. So the cranial nerves are damaged can cause an eye turn to be inward, outward. It can be up or down, but those are a little bit more rare. Signs and symptoms of that is going to be double vision. Eyes may not be aligned. Like I said, they might turn inward or outward. And you may or may not have pupil dilation. So one eye may have a pupil that's a little bit bigger than the other. If that happens, actually, that's typically not diabetes. That can actually be an emergency. But either way, these symptoms happen, like an eye turn all of a sudden, you do want to get checked out pretty urgently, either by your optometrist or by an urgent care or emergency center. If this is diagnosed as diabetes related, it typically resolves on its own just with improved blood sugar control. Other causes that we want to think about is an aneurysm, a stroke, or an injury. And so that's why I say if this is all of a sudden happening, you do want to get checked out pretty urgently, because this can be something very serious that we want to address right away if we need to. Okay. So going to the next kind of set of structures. So the cornea, which is that front windshield of the eye, can have delayed wound healing. So if you have an abrasion on the cornea, it might not heal as quickly as it normally would when you have diabetes. You can also have reduced sensitivity, where you don't necessarily feel that abrasion as well as you did when you didn't have diabetes. You can have an increased risk of corneal abrasions or erosions, so scratches, or basically where you can have those scratches kind of reoccur, which is those erosions. You can also have an increased risk in contact lens difficulties or complications, like infections or ulcers. And then if you were to do LASIK or PRK, which is laser vision correction, you can have increased risk of complications with that. The iris, which is the colored part of the eye, you can see that right here, this structure here. You can have neovascularization of the iris, which is basically new blood vessels growing. And we're going to talk about this in a different aspect in a few more slides, but this can lead to neovascular glaucoma. Again, we'll talk about what glaucoma is in a little bit, but basically new blood vessels can grow, and that is a signal that the eye itself is not getting enough oxygen. And so the tissue sends a signal that we need to create more blood vessels. And so those blood vessels can be leaky and really fragile. And those can sometimes grow into the area where the fluid of our eye drains. And then that can cause the pressure in our eyes to increase, which then leads to glaucoma. And I'm going to talk about this again in a few slides, but that's kind of just a brief synopsis on that. The lens of the eye, which is behind the iris, right here, can develop cataracts and has higher likelihood of developing cataracts with patients with diabetes. So we're going to talk about that for a second. Most people have heard of cataracts. Basically, it is cloudiness of the natural lens inside the eye. So you can see on a normal lens, you have a very clear lens. Light comes through and gets focused onto the back of the eye in a crisp, clear image, so that you can see well. On a patient with a cataract in their lens, the light comes in, and instead of being focused clearly onto the back of the eye, the light gets scattered around. So that can cause blurry vision, cloudy vision, or foggy vision. They can all kind of describe what people see. And you can specifically have difficulty with nighttime driving or oncoming headlights. So those are the common signs or symptoms of cataracts. Now, cataracts can occur just with age. If we all live long enough, we're all going to get cataracts, is what I typically tell my patients. But you can have a higher risk of cataract development when we have diabetes. And so there's different types of cataracts as well that we can see on an eye exam. And certain types, especially types with diabetes, can develop quicker and at an earlier age as well. Other factors for developing cataracts can be smoking, steroid use, or family history. Again, though, too, if you live long enough, most people are still going to get cataracts as well. Okay.
Dr. Alex, I have a
Yes.
question.
Yes.
So I know lots of people who get cataract surgery. And I used to work in the near the OR where it would be cataract surgery day. So once you have a cataract surgery, is there a possibility that you could grow another cataract?
Good question. So the cataract itself is in the natural lens of the eye. When we do cataract surgery, we remove the natural lens and then we implant an artificial lens in its place. So when you implant that artificial lens in its place, it's going into a natural structure called a membrane in the back of the eye there. And so you can sometimes get cloudiness of the membrane. It's not necessarily a cataract is developing again, but it's that cloudiness of the membrane that can cause symptoms similar to a cataract. If that were to happen, then they do a simple in-office procedure with a laser just to break up that membrane and the cloudiness so that patients can see again with that implanted lens. So it's not a true cataract that develops again, but that cloudiness can happen. That seems like it's a cataract developing again. That makes sense?
Yes.
Okay. Any other questions? Okay. So kind of the next few structures we're going to talk about is the vitreous. The vitreous is the jelly-like fluid in the back of the eyes. As we get older, the vitreous does break down naturally, and so we can have what's called vitreous degeneration. This can play a role in diabetic retinopathy, which again we'll talk about in just a little bit, but we can have that vitreous have new blood vessels growing inside it, and that degeneration can affect the retina in the back of the eye. We can also have vitreous hemorrhage, which is basically bleeding into that jelly-like fluid, which can cause decrease in vision, blurry vision, and potentially, if it doesn't clear up, sometimes it can lead to surgery. The optic nerve is the cable cord in the back of the eye. We can sometimes have what's called papillopathy, which is swelling of the optic nerve. We can also have ischemic optic neuropathy, and these are all big medical terms, but honestly, both of these have to do with lack of oxygen to the optic nerve. So the tissue of the optic nerve is just not getting enough oxygen, and it's causing issues like swelling or damage to the nerves, causing vision changes and issues. So we can also have glaucoma, and again, most people have heard of glaucoma. We're going to talk about that for a second here too. So glaucoma is damage of the optic nerve in the back of the eye. So that optic nerve is like the cable cord from the eye to the brain. It sends signals from what we see to where we interpret what we see. When we have damage to the optic nerve, it may or may not be due to elevated eye pressure. So sometimes we can have glaucoma even with normal eye pressures. It just depends on a variety of factors, and you can ask your eye doctor if you're at risk for that. But diabetes does increase the risk of developing glaucoma. Some signs and symptoms of glaucoma is that honestly at early stages you might not have any signs, and most patients don't necessarily know that they have glaucoma unless you have an eye exam. In very late stages you can have tunnel vision, or sometimes patients will just describe it as just very blurry vision. So those are things we want to prevent. And so you can do so by having eye exams on an annual basis and making sure that you're not developing any concerns there. Going back to what I had talked about earlier with neovascular glaucoma, which is where the blood vessels can start to grow on the iris. Again, those blood vessels can be leaky, but they can also just kind of grow out of control. And so they can grow into the area of the front of the eye where the fluid drains. If that happens, then it blocks the fluid from draining, and then that can increase the pressure of your eyes. In that case, then a lot of times you can have damage associated with the high eye pressure. Sometimes this can be really painful, and it commonly is really difficult to treat. So it's something that we really want to prevent from happening. This is usually in patients who have a lot of other diabetic retinopathy issues, which we'll talk about in just a second. But again, it's something that is definitely preventable with annual eye exams and just really good blood sugar control. So we're going to talk about diabetic retinopathy, which is kind of the big thing that most patients think about, or most people talk about when you have diabetes. Diabetic retinopathy happens in the retina of the eye, which is the back film of the eye. So you can see on the picture here, there's the normal retina. You can see the optic nerve on the very right of that normal retina. You can see the blood vessels coming out of the optic nerve, which look nice and healthy. And then you can see the very center of your vision is called the macula. And that's where we see our crystal clear center of vision. Basically, when we have diabetes, we can have damage of the blood vessels in the whole body, but specifically in the retina, that causes leakage of fluid or blood. And so this can also cause oxygen deprivation of the retinal tissues. Signs and symptoms of diabetic retinopathy: there can be no symptoms. So you can have perfectly clear vision, you can see perfectly fine, and you might have bleeding in the back of your eyes. That is identified on an eye exam. You can have blurry vision. You can also have floaters, and you can just have sudden vision loss. So this is a really wide variety of things that you might notice. And so that's why, again, it's important for regular annual eye exams. So there's two different types of diabetic retinopathy. One is called non-proliferative retinopathy. So what this means is that there's damage to the blood vessels that cause them to leak blood or fluid, but there's no new blood vessels growing. So this is typically early stages of diabetic retinopathy complications. When we have the fluid leaking or blood leaking, then that can sometimes cause the retinal tissue to swell because there's not enough oxygen getting to that tissue. So if you look at, I'm going to actually go back to this page. So if you look at the far left image, you can see that there's some blood outside of the blood vessels. That is the leaking blood. You can also see some white areas. So some of those white areas can be that tissue showing oxygen deprivation. It actually turns a little bit white and fluffy. Those are what we call cotton wool spots because they actually look like little fluffy cotton spots in the back of the eye. You can also have areas of white protein deposits, which is where there has been fluid that leaked in the back of the eyes, and then that fluid gets absorbed, but those proteins actually stay in the retina for some time after. And so on an eye exam, we can see if there has been fluid previously too, not just present on that same day eye exam. Treatment for this is typically just improved blood sugar control. So there's different grading levels of this condition, and typically in the mild and moderate, blood sugar control is really the main treatment. In more advanced cases, we may start to consider doing other things depending on how the retina is looking, if there's any additional concerns as far as like iris neovascularization or issues with that. So again, blood sugar control is what it comes down to. Proliferative retinopathy is where there's new blood vessels growing in the retina, which helps supply the retina with enough oxygen to function properly. So when we start to have leaky blood vessels, that tissue in the back of the eye is not getting enough oxygen, and it starts to send off signals saying, hey, we need more oxygen. That then stimulates the blood vessels to start growing. And those blood vessels are weak and they can be leaky, leading to more bleeding in the back of the eye, or the vitreous, which is the jelly-like fluid in that back of the eye. So this can lead to scarring, which can then also cause a retinal detachment or retinal tear. So a lot of times those blood vessels will grow, they're really weak and they leak. And a lot of times then too, they can become kind of scar tissue. And if you've ever had surgery or injury that leads to a scar, you can kind of tell that it kind of puckers at the tissue or the skin. And that's because scar tissue typically contracts. And so when that contracts, it can pull on the retina, and that's what can lead to a retinal detachment. Typically when we start to see this, and actually let me go back here. So looking at this diagram right in the center, you can see all those different aspects that I had talked about earlier with the leaking blood, but you can also see these little thin blood vessels right here. And you can see that they're a little bit smaller, they are typically weaker, and that's what is that new blood vessels growing. It can happen on the optic nerve. It can happen anywhere else on the back of the eye. This picture just shows that optic nerve. So treatment for this condition can be using a laser, it can be injections, or it can be surgical. So it just depends on what the actual issue is. If we catch it early, a lot of times we can just do a laser. They are starting to use injections a lot more to help reduce those signals that get sent out saying that new blood vessels need to grow. So those are some different options there. Now in the center of your vision is called the macula. That is where we see the crystal clear center of 20/20 vision. If you've heard of macular degeneration, this is where this is located. I'm not going to talk about macular degeneration, but I am going to talk about diabetic macular edema. Now, what this means is that there's fluid located in the macula of the retina, that center of vision, from those leaky blood vessels. So if you look down at this bottom image, this is what's called an OCT. It's kind of like a cross section of the macula. You can see that it has a nice little indentation, and that indentation is what the macula is right here. On the right, you can see there's a lot of kind of black spaces, and that is fluid actually in the tissue of the macula. So those leaky blood vessels have allowed fluid to get into the center of your vision. When we have that disruption, it can cause blurry vision. It can also cause wavy or distorted vision. Colors may not be as vibrant. And a big issue with this is that it might only occur in one eye, which can then delay diagnosis and treatment. This is actually the most common cause of vision loss in patients with diabetic retinopathy. You can have diabetic macular edema without retinopathy, and you can have retinopathy without edema. So these are two separate things, even though they both come with like the leaky blood vessels and fluid accumulation in the retina. So it's something we want to catch early if it is happening. Again, sometimes though it can happen only in one eye, and so then it delays treatment because we usually see with both eyes open, and so the other eye can kind of cover up the eye that's maybe having the symptoms with it. Okay. So how can we prevent some of these issues? So annual eye exams are typically what we can do to help prevent this. Some of the guidelines from the American Optometric Association is that patients with type 1 diabetes should have eye exams beginning in puberty or 3 to 5 years after diagnosis. There is the concern, however, that if you wait 3 to 5 years after the diagnosis, that you might delay the diagnosis of retinopathy. So there is that concern starting to happen. So honestly, I always recommend initial diagnosis, come see us. Patients with type 2 diabetes, you should have an eye exam as soon as possible after diagnosis. This is because the difference in these two recommendations is because there's an assumption that a patient has probably had uncontrolled diabetes for quite some time before diagnosis. Type 1 diabetes typically has a lot quicker onset and a lot more severe symptoms initially. And so they can diagnose that a little bit faster, whereas patients with type 2 might have it slowly creeping up. The blood sugar might just slowly creep up over time. And so it might not be detected or diagnosed as quickly. Patients with who are pregnant with diabetes, if you're a patient who has type 1 diabetes and you're pregnant, it can increase the risk of retinopathy. And so increasing the exam frequency during pregnancy and the first year postpartum is what's recommended. If you typically don't have diabetes, but you are diagnosed with gestational diabetes, that typically does not lead to diabetic retinopathy. And so there's not really any increase in recommendation of eye exams. So prevention, how can we prevent these issues? Good blood sugar control. I talked about this kind of throughout the different diagnoses, but that's going to be the number one way that we can prevent complications with diabetes. It's really important that you know the glycosylated hemoglobin, your HbA1c. Most providers, most doctors are going to ask you about that. And it's just a good way to know the average of blood sugar over a 3-month time period. So we kind of get to know how well your blood sugar is, or as far as one reading is not just going to be really high or really low, it's going to show us the average. You can also make sure that you have good blood pressure and cholesterol control. When I was in school, actually, there was a professor who commonly liked to talk about how only about 7% of patients had good blood sugar control, good blood pressure control, and cholesterol control. So only about 7%, if someone was diagnosed with one of those, only about 7% of patients had good control of all three of them. So it's something that's really important and it's really difficult to do, but can definitely help prevent issues. Quitting tobacco use. So diabetes already can cause oxygen problems, and so tobacco use can also contribute to that factor. Making sure that you have healthy diet and exercise can help prevent these complications. And then dilated eye exams yearly or as recommended. Your eye doctor may recommend more frequent dilated eye exams depending on what they see in the back of the eyes. Again, the eyes provide a view of the live blood vessels without having to do invasive imaging or surgery. So it's a really good way that we can check to see how the blood vessels are functioning as far as if they're leaking or having any issues there. And that is my talk. Any questions?
Hey, Dr. Ellis, this is Desiree. I had a question about the macular edema. Is that something that you have to treat, or is that something that with better blood sugar control goes away?
Yeah, so we do typically recommend, well, I should say, so me as an optometrist, I typically refer that because we do want to have it evaluated by an ophthalmologist, and they honestly, it depends on how severe it is. If it's not very severe, then they a lot of times will watch it. But sometimes we will treat it. And at this point, I believe the treatment is injections to help reduce the swelling in the center of the vision. So,
what are they injecting?
So a lot of, well, it just depends on, there's a couple of different injections. So the names of them can be, it might be Eylea or Avastin, which are what's called anti-VEGF. So VEGF is vascular endothelial growth factor, which is what what the retina sends the signal to grow new blood vessels. And so even before the retina starts growing new blood vessels, there's this molecule present sending the signal. And so a lot of times they'll do an injection of an antibody. It's an antibody essentially that helps to kind of neutralize that signal molecule.
I had one other question too, because I know that a lot of times you can, like, especially with like protein deposits, do they inject anything that can go in and dissolve protein deposits, or are those protein deposits like permanent?
So no injections are needed for those. They typically do resolve. It can just take a lot longer than the fluid that had initially brought the protein into the retina. So those are self-limiting.
I should see if anybody has any. No, we don't seem to have any chat questions. Anything else?
I don't think so. Oh, I was gonna ask, so for eye exams, because a lot of times we don't see folks come in because they, you know, for most part, people are healthy up until a certain age, you know, and then they're like, oh, I gotta find a provider, you know. So when do you recommend just folks start getting an eye exam if they don't have like visual problems?
Yeah.
And how
So, I mean, I typically recommend eye exams every year, regardless of your age. I believe the American Optometric Association recommends up until age 18 doing an eye exam every year. And then I believe between 18 and 35 or maybe 40, it's every 2 years. And then over the age of 40, I believe it's back down to 1. Now, it honestly just depends. I mean, some patients I'm seeing for the first time when they're 38 because they're starting to have vision issues. Definitely as you get older, you do want to have make it a point to have an annual eye exam, because that's when you're going to start having a lot more complications, not just with diabetes, but glaucoma, cataracts, what's called presbyopia, where we have a hard time seeing up close. So those are all going to start being more prevalent as you're getting older. So I know that's not really a hard and fast answer. If you're able to do annual eye exams, I would definitely recommend it. But definitely as you get older into your 40s and 50s, you want to start getting in the habit of doing annual exams.
Now we know that some diabetes medicines work in different ways. Like we have some that are cardiovascular protective and things like that. Have you, as someone who deals with eyes, have you noticed any differences with people who are on different medications? Like, different side effects or different outcomes that might be related to what kind of medicine they're on?
Yeah, that is a really good question. I don't believe I've necessarily noticed any specific pattern associated with medications. I do believe they've found that if you're insulin dependent, then you can be at a higher risk for complications. I would just say insulin dependent would be a higher risk for for complications. Now, one thing actually that I did not mention in this talk is that even if you have really good blood sugar control, the length of time that you've been diagnosed with diabetes can actually have a really big effect as well. So even if someone has perfect blood sugar control, if you've had diabetes for 20 years, you may still start to show issues, just because the damage of the blood vessels over that time, even if your blood sugar is not super high, you can still have just minute changes. So patients like type 1 diabetic patients can still have issues even if they have really good control. I mean, I should say type 1 and type 2, but so if a patient is type 1 and they get diagnosed at 18 years old, they may start having these issues regardless of whether or not they have good control starting in their 30s. So that's something just to make a note of.
Mm-hmm. Mm-hmm.
Does anybody have any other questions? If you don't want to, use your voice, you might want to just hit the chat button.
Well, it doesn't look like there's any further questions, Dr. Ellis. We sure appreciate your time. Yeah, this was super interesting. Quite a bit. I just knew about diabetic retinopathy. I didn't really know about all the other. So that was really interesting. So thank you.
Yeah, you're welcome. Thanks for having me.
All right.
My email's down there. If anyone else has any other questions that you think of later, you can just give us send me an email and then give us
Absolutely.
an exam.
And sometimes that does the questions come up a little later and
that
kind of thing. So awesome.
All right. Well, thank you so much.
You're welcome. Thank you.
Have a good weekend.
Thank you. You too.
All right. I'm going to